My name's Phil O'Connor, one of the musculoskeletal radiologists at Leeds Teaching Hospitals Trust in the United Kingdom. And I'm going to talk a little bit about imaging of muscle and imaging muscle injury in particular. So in the lecture, what we're going to do is talk a little bit about the structure and anatomy of muscle, normal imaging appearances, and then we're going to look at the pathobiology of a few conditions that can affect muscle, particularly injury, inflammation, and then just a tiny bit about denervation change. So in terms of muscle structure, you can see that muscle has a hierarchical structure with muscles made up of multiple fascicles, which are in turn made up of multiple muscle fibers, which then contain myofibrils. The muscle fibers are single-celled structures, and if you look at the fibers themselves, they're quite long. They measure 10 to 40 millimeters in length and approximately 10 to 80 micrometers in diameter. And they can be extremely long and extend through the entire muscle, reaching up to lengths of 35 centimeters. There are two main muscle fiber types quoted, type 1, the slow-twitch fibers, and type 2, fast-twitch fibers. And they really are defined by the myosin ATPase activity seen within the muscles. Although people do quote the fact that there's two types of muscle fibers, in reality they're actually the extremes of a continuum. And there are 7 recognized muscle fiber types now present. And there's some evidence to suggest that you can change the balance between fiber types in your body by training your muscles. So if you look at the muscle fibers themselves, fast-twitch type 2 fibers have larger diameters than slow-twitch fibers. So when you're building muscle, if you build fast-twitch fibers, then you tend to increase the muscle volume more than you do with type 1 slow-twitch fibers. And up to 68% difference in size between type 2 and type 1 fibers is seen. So what happens to muscle fibers in exercise? Well, in general, untrained individuals have about a 50-50% ratio of fast to slow twitch muscle fibers in their body. And if you train as an endurance athlete, that alters so that you have more slow twitch fibers. So you tend to get a 70-30 distribution, or up to a 70-30 distribution biased towards type 1 fibers. And then if you're a sprinter or a power athlete, such as a weightlifter, then you can change your distribution more in favour of type 2 fibers, not to the same extent as endurance athletes, but you can get a 60-40 distribution of type 2 fibers in your muscles. So when you're looking to image muscle structure, you need to be aware of this hierarchical structure and a little bit about the different fiber types. You need to look at the actual how the muscle's made up, and in general muscles are bipennate or unipennate, and then you need to know a little bit about anisotropy. Anisotropy is defined as tissues that have different properties dependent on the direction in which you look at that tissue. So with imaging, it's tissues normally with multiple parallel interfaces that behave differently when viewed at different angles. So this is the typical appearance of a bipennate muscle. If I just overlay an ultrasound image there, you can see the typical appearance here. You can see the tendon coming in, and then the tendon stretches out and thins out in what some people term the myoaponeurosis. So this is an intramuscular portion of tendon that slowly peters out and finishes quite far down the thigh in this patient's rectus femoris. And from this feed off the muscle fibers. And you can see that the muscle fibers have got quite a low pennation angle, certainly less than 90 degrees. And then in between the muscle fibers, you've got little septations, which are these bright areas of fat and fibrous tissue. And these are the little bits of tissue between the muscle fibers themselves. And this is the typical appearance of a unipennate muscle. Here you can see I've used the gastrocnemius as the example to overlay across this muscle. And you've got the head of the patient over here on the right of the screen and the foot of the patient over here on the left. And you can see the gastrocnemius fibers coming to insert down on the myoaponeurosis that extends inferiorly to form the Achilles tendon. Anterior to that, you've got the soleus myoaponeurotic fibers. And this is where understanding your muscle anatomy and functional anatomy is really important, because these muscles have different actions in the calf, slightly different actions, not completely different. And what you have is the gastrocnemius inserts above the knee on the posterior aspect of the femur and extends down to insert on the calcaneus below the ankle joint. The soleus arises from the proximal aspect of the fibula and the interosseous membrane and extends down to insert on the calcaneus. So the degree of movement seen in these muscles really depends on the degree of knee flexion present. When you flex the knee, you defunction the gastrocnemius. And so the soleus tends to move more and has a greater degree of craniocaudal movement than does the gastrocnemius. And exactly the opposite happens when you have the leg straight. Gastrocnemius now moves more than the soleus. And what that means is these myoponeuroses here cannot be fused, so they have a potential space within them. And one of the mistakes a lot of people make when imaging tennis calves or a common injury in this area is they assume that the tear size is the same size as the hematoma. But what you have is this potential space between the two myoponeuroses that can fool you into thinking that the tear is a lot bigger than you really think it is. When you're looking at muscles with ultrasound, anisotropy is your main problem. So if you have the beam going at slightly different directions, you can see the muscle properties change quite dramatically. So you can see here you've got quite dark muscle, and as I change the beam angle, you can see the fibres become quite bright and then dark. And what you're really looking for when you're imaging muscle tears is loss of this anisotropy. So you can see here in this central portion here, there's an area of muscle that's not demonstrating any anisotropy, and it's lost its normal structure. There's no little septa within it, and this is a muscle tear seen with ultrasound. So this is just a demonstration of anisotropy. What you're looking at is multiple parallel interfaces within the tissue of interest, and when these are aligned parallel to the surface of the transducer, you get a very good reflection of the sound back towards the probe, and hence you get a very strong, bright image. If they're not parallel, they tend to reflect the sound away from the probe, and then the tissue looks very hypoechoic with a poor reflection seen at ultrasound imaging. So this just demonstrates that appearance again in the soleus and gastrocnemius. I'm using electronic beam steering here, and you can see with the beam just going straight down, the gastrocnemius, which is the more superior portion of these two muscles, is hypoechoic relative to the soleus, which is slightly more parallel to the surface of the probe. If you beam steer to make that so that it's not as parallel, what you now have is you've equaled out the echogenicity. So now the gastrocnemius and the soleus are the same echogenicity. And if I beam steer the other way, you accentuate it. So now you can see soleus is a little bit brighter and the gastrocnemius has gone even darker. So you can play around with the anisotropy. And sometimes it can be quite a useful artifact to use to demonstrate tendons and tissues that have got multiple parallel interfaces. With regards to muscle imaging, you tend to see less spatial resolution, and you don't really get the internal structure that you see with ultrasound. You can see here this is an athlete with well-developed muscles, and you're not really seeing any of those fibrillar patterns within the muscles of the patient's pelvis here. You can tell this is a soccer player. He's got typical changes in his symphyseal cleft that we see in the UK. You can see he's lost a subchondral plate here on the left, and he's got a little bit of high signal just undermining the origin of that left adductor longus, and that's typical features of adductor disease and osteitis pubis with a secondary cleft sign. He's also got some hip disease. You can see he's got some cartilage and labral damage superlaterally with really quite marked edema in the femoral head and a little bit of edema on the acetabular aspect of his hip joint associated with a large joint effusion and synovitis and debris in the hip joint. Luckily, this lack of detail in the muscle isn't so important because when muscles get damaged on MRI, they tend to get edematous or hematoma forming within the muscle, and that makes muscle imaging with MRI extremely sensitive to muscle change. And sometimes it can even be too sensitive, because often athletes recovering from muscle tears can have quite dramatic muscle MR changes, but be ready to return to play with really good, strong healing having occurred. So what sort of pathobiology are we dealing with? Well, we're going to talk a bit about muscle injury first, then inflammation and denervation. Muscle injury can be caused by either direct or indirect injury. Direct injury is sometimes called contusion and relates to direct trauma to the muscle. Indirect injury is a stretching or overloading injury during training or activity, and this tends to occur at the myotendinous junction, which forms the weak point of the kinetic chain in young athletes. When you get a muscle tear, it tends to go through phases. So say muscle tear occurred at day 0 here. You tend to get platelets released into that muscle tear via the haematoma, which stimulates a healing response, which is characterized by inflammation over the first 1 to 3 days. And after that, you get a cellular proliferative response with fibroblast activation and the beginnings of muscle regeneration, scar formation, and that occurs up to about 30 days. And then remodeling of that proliferative new tissue tends to occur after that phase and can go on up to about 100 days post-injury. What are you imaging when you're imaging muscle injury? Well, fibre disruption really is what you want to image, and that's the key thing. How many fibres are actually torn, and what is the gap that's been created at that tear site? Haematoma is very useful when imaging muscle tears. The actual size of the haematoma isn't the important factor, but the haematoma can be very useful as acting as a contrast agent to show you the degree of fibre disruption that's present. And then later on in the looking at muscle tears, you can look for inflammatory reaction and healing change with regeneration, scar formation. And you can also look for denervation change, which might affect the function of a muscle later on. So how do you differentiate direct injury from indirect injury? Well, clinical history is a good way to start. If the patient has a history of direct trauma to an area followed by bruising and pain in the muscle, it's likely to be a direct injury. If they pulled up during a sprint with hamstring pain, it's going to be an indirect injury. The imaging findings that give you the clues are sometimes useful, because sometimes your physicians are not as communicative as you'd like and don't tell you the mechanism, or sometimes the athlete just doesn't know what the mechanism was. He was on the floor in some sort of grappling situation, and when he got up, he had a painful leg, and you don't know whether it was direct injury or indirect injury. So direct injuries tend to cross anatomical boundaries, and they don't occur at the myotendinous junction. So to give you an example, this is two direct injuries. One's a thigh in someone who's taken a direct blow to the anterior thigh, and what you can see is edema present in multiple tissues. So you've got subcutaneous edema. This is the superficial femoral neurovascular bundle. You can see there's edema in the sartorius, then in a perivascular position, and then in the vastus intermedius as well. There's quite marked muscle damage and edema, even down to the periosteum here. You can see some periosteal edema adjacent to the femur. Typical appearances of a contusion without any substantial hematoma formation. So that's going to be a pretty good prognosis, contusion. Same thing at ultrasound. You can see the change in the subcutaneous compartment, a little bit of hematoma, some altered signal in the fat. And you can see this loss of the normal muscle hierarchy extending down through muscle boundaries. And you can also see there's some swelling of the muscle. So you can see the muscle's a little bit thicker than it would normally be. This capsule is lifted up. And you see the same sort of appearance here in the sartorius. Very typical for direct contusion. Hematomas are not unusual in these cases. They're closed injuries quite often. So here you can see a vastus intermedius. This is a centimetre scale, so this is a 15 centimetre hematoma in this patient's vastus intermedius. You can see that it's a direct injury. You can see the altered echogenicity here in the rectus femoris overlying it where the patient's taken the trauma. Same thing on the axial views. If you're going to aspirate these, it's best to wait till about 10 days when you can start to see liquefaction in the hematoma. This is the same sort of appearance at MR. This is a rectus femoris hematoma, and you can see this having quite marked mass effect, with flattening out of the tissues around it in a patient with a really nasty-looking hematoma that could do with aspiration. So, when to image? Well, that's not too important with MRI. You can image fairly early. We've imaged tears at less than an hour with no problem whatsoever. The hematoma forms very quickly and really gives you a good idea about how severe the tear is. If you're thinking of doing ultrasound to image these tears, it's quite important to think about when you do the ultrasound. What you need is contrast between that hematoma and muscle, and you find that develops over time, and it's actually better 48 to 72 hours post-injury. I've got a few examples here. These are taken from muscle injuries that have occurred at major athletics competitions. So this is a case from the World Indoor Athletics Championships in Birmingham, and this is a long jumper who came straight off the track, straight onto the ultrasound scanner with a hamstring tear, and we imaged him. And this is the hematoma here, this very bright tissue extending around the biceps femoris myotendinous junction here. So you can see it's very hyperechoic and virtually identical to the dense connective tissue in the subcutaneous compartment. So it makes it very difficult to really grade that tear when you've got such bright hematoma. This is a slightly older tear. This is 2 hours old. You can see there's a tennis calf. You can see the hematoma formation tracking in that potential space between gastrocnemius and soleus. And you can see the extent of the tear with the myoponeurotic disruption and muscle edema present. You can see that the hematoma on ultrasound is still very bright at 2 hours, and you can see the increased pennation angle in the gastrocnemius indicating there's a tear at this site. Now, if we go a bit longer, go out to 36 hours, this is probably the perfect time to miss a tear at ultrasound. You can see here there's a sizable hematoma here present, but it's virtually isoechoic to the surrounding muscle. So that's your hematoma there, but it's really very difficult to appreciate on the ultrasound scans. And if you wait a bit longer and go out to a number of days, what you start to see is liquefaction of that hematoma. So again, this is a tennis calf, extended view image showing the hematoma liquefying with little lumps of clot sitting within this fluid. So the best time really to image these tears is to image them later rather than early with ultrasound. And at that time, you use the contrast between the fluid and the muscle to show you how severe the tear was. All these problems with ultrasound tend to give you a relatively low sensitivity for ultrasound compared to MRI. There's not many papers on this, but one nice one looking at 81 soccer players was reported in the Italian literature. And there they found that for minor injury, ultrasound had a sensitivity of 75%, and for major injury, 92%. So you can imagine in professional athletes missing 1 in 4 minor tears and 1 in 12 major tears is not ideal. And there was quite a high incidence of false negatives in these athletes. So for us, MRI is the first-line imaging technique for imaging muscle tears, and we reserve ultrasound for imaging of problem cases and for interventions in these patients. So indirect muscle injury, we're just going to move on to that a little bit. This is occurs at the weak point of the pneumatic chain at the myotendinous junction. It tends to affect fast-twitch muscle fibers, muscles, so these are the hamstrings and the quadriceps are the commonest. And it tends to affect muscles across 2 joints more than single joint-crossing muscles. So when you're looking to assess these muscle injuries, the first thing that you need to compare to is the clinical assessment. This is a cricket player from the UK who has this tiny little tear of his biceps femoris. You can see a little hematoma around the capsule, but no real muscle edema, no fibre derangement, very low-grade tear. But when this athlete came off, and for the 24 hours they were assessing him, they really thought this was a very severe injury. He came off on crutches and was in agony when he came in. and he was back playing within 7 days. So, it can be hard sometimes to assess them clinically. So what you then go on to use is an imaging grading system. And the one thing that you'll see is there are lots of grading systems available. The commonest ones in the UK are the O'Donoghue, the modified Pitron, and the British Athletics muscle injury classification systems. All I can tell you is where you have lots of systems, normally each of those systems has problems. And I think I'll explain that a little bit to you as we go through. So what you tend to have is a low grade tear, and these are a small volume of muscle is affected with very little fibre disruption. So you tend to get muscle edema without fibre disruption. So this sort of feathering around the myotendinous junction. And when you see this very low grade injury, this is associated with full recovery within 2 weeks. And then at the other end of the spectrum, you've got high grade injuries, and these are complete disruption of all muscle fibres in that muscle group. And this is a severe injury, giving you a greater than 12 weeks recovery time. Now, you have to take the quoted recovery times in the context of the sport the athlete's being asked to undertake. So a lot of the papers looking at recovery times relative to grading are based on Australian rules football, and they seem to get back a little bit quicker than I find with our soccer players. So you have to modify sometimes your assessment of these injuries with the sport when you're giving advice as to recovery times in these patients. So this is a complete tear. You can see the haematoma here in the rectus femoris with this loose piece of muscle hanging down into the haematoma. Same thing on MRI with a loose flap of muscle hanging down in the haematoma. This is known as the Bell-Clapper sign of a patient with a very high-grade disruption of that muscle. So those are the two ends of the spectrum, and everything else is somewhere in between. And what your classification systems do is really fill in the gaps and try and assess them. And they've all got problems of their own. So the O'Donoghue really is almost like a binary assessment where all tears virtually end up as grade 2. The BAMIC system is quite nice. It's based around whether there's tendon involvement at the tear site, but I find it very hard to use in practice for 2 reasons. The first reason is it's hard to tell where the tendon starts and finishes because these tendons extend intramuscularly for quite a long way. So it's difficult to know when they become extramuscular to say there's tendon involvement for that classification system. And the other problem with the BAMIC is it's not really been around for a long time, so we don't, as yet, know what it means. So I tend to use the modified Pitron, but I'm moving towards using a BAMIC nowadays. I've got a few tips for when you're grading these tears. First one is direct injuries always heal faster. So although they look dreadful, they're a lot quicker to heal than the indirect injuries. The more myoponeurotic redundancy you see, the more severe the injury. So when you see the myoponeurosis is not straight, it's irregular and slightly redundant looking, then that's a higher grade injury. And that's going to push you over towards the 8 to 12 week recovery time. The other thing is that tears should always be improving after the first couple of weeks. And if they're not, you need to start thinking about complications, myositis ossificans, or other problems that may be occurring in that muscle. Just going to talk a little bit about muscle inflammation. Myositis has a variety of causes. The main cause we see is autoimmune. This tends to affect young to middle-aged patients. The two main types we see are polymyositis and dermatomyositis. Dermatomyositis has a higher association with paraneoplastic syndromes. Inclusion body myositis tends to occur in older patients, so it's rare in patients under the age of 60. And unlike polymyositis and dermatomyositis, has a slightly asymmetrical distribution. And then proximal myopathy tends to be seen in patients most commonly on steroid therapies. So autoimmune tend to be symmetrical. Dermatomyositis is associated with a lot of fascial involvement, so when you see muscle inflammatory change, you also see fascial involvement with fascial calcification also present. Inclusion body tends to give you a very asymmetrical involvement with patchy involvement of different muscle groups, and proximal myopathy tends to give you proximal muscle edema. So if you identify the distribution, that's the first step. This is a typical appearance of an acute polymyositis. You can see this patient has quite gross abnormality in the muscle here of his right thigh. This is normal. This medial vastus medialis is pretty normal, bit of edema here, but all the other muscles are showing diffuse muscle edema. And it's just like a little bit of greying out of the muscle. A little bit of fascial involvement, but not too much, and no fat atrophy on the T1 weighted scans. So that's someone who's got polymyositis, and what we're really being asked to do in a lot of these cases is to identify a target for muscle biopsy. And here you pick the most active area. So vastus lateralis would be a perfect site for muscle biopsy here. Compare that to this case, you've got a much more advanced myositis patient with quite marked fat atrophy in the vastus lateralis and intermedius here, with muscle edema in the vastus medialis and also in the rectus femoris. Some involvement is also present in the hamstrings, with patchy involvement here of the medial hamstrings. So what you've got here is a patient with quite asymmetrical, patchy involvement, and this is typical for inclusion body myositis. These distributions, though, aren't diagnostic, and what we're really looking for here is the area that's most suitable for muscle biopsy. And in this case, we'd go with the vastus medialis because you've got relatively little fat atrophy and the most active muscle change. And this is a patient with dermatomyositis, just showing you muscle edema here in the gluteal muscles with this quite extensive fascial calcification extending round, and a little bit of fascial edema also present, most marked here on the left side. And that's a typical case of dermatomyositis. Denervation change. Well, the motor units from the spinal nerves innervate different nerve fibres, type 1 and type 2, and what you tend to see when you get denervation change is you can get cross innervation from different fibre types across these areas. So what you tend to see in a denervated muscle is what's called clumping of the fibre types. So on the left here we've got an ATPase stain showing type 1 and type 2 fibres. And what you see on the left is the normal distribution with just an even distribution of type 1 and type 2 fibres. In a denervated muscle, what you tend to see is clumping of the fibre types. So you can see the type 1 fibres here and type 2 dark fibres here clumping together in an unusual distribution. So what we see in denervation is acute change, which is edema, and then chronic change, which tends to be fat infiltration. And you can see both together. So this is a patient who's presented with a left rectus femoris muscle tear. You can see it's got myoponeurotic redundancy, muscle edema with a reasonable sized tear and a sizable extramuscular hematoma. And if you look on the contralateral side, what you can see is the patient's had a previous tear of his adductor longus. So you can see the scar formation here. And then you've got this low-grade increased signal on the stir sequences in the adjacent muscle belly. And when you compare that to the T1 weighted scans, what you can see is you've got some fat infiltration here within the muscle. Fat shows up as high on the T1 weighted scans. And you've also got some edema present within the muscle here. And that relates to denervation of the muscle. If you imagine the nerves enter proximally within the muscle and pass distally. So when you have a tear site, there's nearly always a degree of denervation change present distal to the tear site. And these are the sort of appearances that you see. This is a more severe case of denervation change where you can see the entire soleus and gastrocnemius muscles have turned to fat with gross fatty atrophy present in these cases. You can see the patient also has a large common perineal nerve ganglion sitting in the perineal group here. So in summary, I hope I've given you some idea about how we look to image muscle in a clinical setting with MRI as our first line investigation of choice. We then use ultrasound as our second line investigation for problem solving and intervention. And I just think you need to be aware of the problems that you're going to see with trying to grade and classify these muscle injuries, and be clear in your own minds about what you're using muscle imaging for in patients with trauma, inflammation and denervation. Thanks very much for your attention.